Welcome to Debunked, where we analyze healthcare news with a healthy dose of skepticism and call out industry practices that seem entirely insane to us. I am Arundhati Parmar, Editor-in-Chief of MedCity News.
And I'm Samir Batra, the Managing Partner for HIP. We're a healthcare venture firm.
Now, Samir, when we talk about healthcare and bad practices, we generally tend to pounce on what I think are sort of the easy villains, the pharma. They're so greedy, they, jack up drug prices, the PBMs, the middlemen. We think of, vendors that sometimes, bill poorly. But today I wanted to speak about folks that generally we revere. And I grew up in India, Samir, and you know that. And there, doctors are truly, truly revered. Just in 2018, my mom had to go through spine surgery, and she decided that she was going to go with her spine surgeon in India, Dr. Shomajit Basu. She had back surgery in an emergency basis in the US. Okay. And like the surgery, didn't like sort of what led to the surgery. Anyway, so she was like intent, no, I'm not coming to the US, I'm going to get it done in India. So obviously, I took the 20-hour flight down. And okay, so it's the day of the surgery. I'm there, tense. The doctor had told me to take a certain amount of time, and it was taking longer than that. So me being the deeply impatient soul that I am, keep going up to the front desk, inquiring what's going on. At one point in Bengali, I kind of mused out loudly, I wonder if something has gone awry. Yeah. And almost immediately, there was a male nurse who apparently worked with Dr. Basu, and he said, very calmly, he looked at me and said, nothing ever goes awry with Dr. Basu. And I'm like, wow, this is like the supreme confidence of that. Mm-hmm. Completely shook me. And then obviously my mom had a great surgery, she recovered very well. And she also kind of thinks he's God. So all good. So I grew up in that environment. And even in the US, I've encountered really great physicians. I mean, I have to give a shout out to Dr. Matt Scala from Kaiser Permanente. He was my dad's radiation oncologist. And the patience he showed in sort of dealing with my dad, who's like 80 years old and going through prostate cancer, just phenomenal. But, a little bit over time, I've sort of felt disenchanted with this group. And I see that providers and hospitals and hospital workers, all of whom that I have great respect for, have their hands quite deep into the proverbial cookie jar that is the US healthcare system.
What are you referring to?
Okay. All right. So I don't know if you've heard of this. This is something called site-neutral payments. So let me step back and define it for you as I understand it. Yeah. So Medicare wants to standardize how they pay for outpatient services, regardless of sort of the type of healthcare facility the procedure is being done. Mm-hmm. So say, for instance, you need imaging and you go to your local outpatient, imaging center, mm-hmm. get it done. They charge you at a certain rate than if you were at the hospital. Yep. Because hospital is more acute, apparently there's more expertise, so same exact thing costs more. What now health systems are doing and hospitals are doing is that they're buying up these outpatient medical centers and different, it could be physical therapy practices, and then they're using their national provider number.
Yeah, their NPI.
Exactly, and charging private and public insurance these jacked up hospital rates for the same exact thing that you got cheap before that acquisition happened. So that God status is being threatened a bit, and I'm feeling more and more that I'm seeing this, sort of double dealing happening more and more with providers than I've ever seen before. Do you have the same experience?
Well, first of all, I think that's totally gangster.
Gangster.
I love it.
Oh my God.
Keep doing it. That's so baller. Because you know what? They sit there and say, look, you're going to come to me, and yes, you're going to get the same imaging, a procedure or whatever it may be. But their whole claim is, look, I'm running a hospital.
Yeah.
You might have acute issues. You might need to be rushed, right? So you're coming more to a well-rounded structure that can deal with complications. Mm-hmm. Where outpatient, something goes wrong, whoopsie-doo, you're going to have to call, emergency, And then they're going to 911 you to my facility anyways because I'm a hospital. So I'm just sort of saying, right? That's what they're claiming.
Right.
But let's just be honest. Last time I checked, if you actually do go to an imaging center in a hospital and there is a complication, you're going to wait a long time to see an expert or go into an acute setting. Last time I checked, not all hospital-owned clinics or outpatient services are in the four walls of the health system as well.
True.
So I can't give them credit. It's totally baller. I mean, they've been getting away with it for so long. It's totally extra. But yeah, like you kind of are telling me that, the example I give is, it's like you go to Safeway to buy something. Safeway is a grocery store here in California. And you find like a bag of organic pasta. Okay, and then you go to Whole Foods, and that same brand of organic pasta is more expensive. You're like, what the hell, man? Why? Because Whole Foods is like, we're Whole Foods.
Yeah.
Right? We're Whole Foods. So it's kind of like the same thing. Now, they've gotten away with it for
a long time.
But,
Well, not anymore. If Congress has anything to do with it, I think there are 6 bills. We wrote a story on it. We'll put it in the description box of our video. But there are apparently 6 bills out there that are trying to enforce this. Obviously, the American Hospital Association is fighting it tooth and nail. Their perspective, and again, I welcome folks from the AHA to come to our show and discuss their perspective. But what they say, as far as I understand, is that if these bills become law, then there's a chance that $1.4 billion will be taken away from the hospital system over 10 years. And they are warning, cautioning, threatening, I don't know what the right term is,
all of the above,
that certain service lines will be eliminated because they just don't have the financial wherewithal to deal with these lower pay cuts, right? So they worry that physical therapy service lines may be shut down. They worry that imaging may be shut down. But again, I don't know. I don't have the it's above my paycheck to figure out whether these estimates are truly what we should all be worried about, or whether we should be, and I feel like I'm on the side of the patient where I don't want to pay this extra amount if I'm getting the same thing done, at an outpatient center owned by the hospital as opposed to an outpatient center not tied to anything, right? Yeah. So curious, again.
Yeah, I mean, look, first of all, let's back the truck up. Like, how did this even happen the first time? Right? And I blame hospitals propose this whenever. Government let it happen, payers let it happen, Medicare let it happen. So first of all, own up to it. Now they've taken advantage of it for, quite some time. Mm-hmm. Look, the other thing is, I mean, to your point, right? They're sitting there saying, look, I'm having to pay for all these additional services around just this one, facility that I have that's outpatient or whatever it is. And then using their own NPI to bill, right? To sort of extend the care. But at the same time, this is sort of a build up or build on with the Patients Act, right? And I have my issue. I have some, thoughts about the Patient Act as well. The Patient Act obviously says, dude, total price transparency, right? Everybody's got to publish your pricing, and it's got to be out there in front of everybody. What's really interesting about that is price transparency does not necessarily mean price control and price choice.
Sure.
It just means, I'm just going to tell you how much it is.
No, but I'm going to push back on that. I mean, that's the first step. Right?
It is the first step.
I mean, unless you brought stuff into the sunlight, into the light, you don't know what kind of bad practices are going on. Now we know.
Yeah.
If I go to my local hospital, you, Samir, have Aetna insurance. Yeah. I don't think they have Cigna insurance. We go through the exact same procedure. What you pay and what I pay is completely different for the exact same thing. Now, if there were no price transparent, we wouldn't even know that. So that, I think, is the first step.
Yeah, it is. And I think it's a good first step. I think hopefully over time that price transparency will lead to better pricing and more competitive pricing and choice. Because sometimes what happens is you're like, okay, well, I got to go do this procedure, and your insurance will say, this is how much it costs. Okay, well, what if I go to another clinic? Doesn't matter, this is what it costs.
Yeah.
So what choice do you have? Great, I just know what the bill's going to be.
Yeah.
That's the only thing that you've told me, is that I just know what the bill is.
Yeah.
Right. So I think there has to be some sort of more movement on that side.
Right. And I also wanted to question you on, letting it happen. I mean, government let it happen. I think everyone is, equal opportunity to blame here when it comes to healthcare, right? Everyone has had their vested interests. And now suddenly, because fee for service is unsustainable, now we have to look at all these things and, we're now all for patients, right? So I think the blame, you can't just blame one group.
No, and you're right. And look, and of course, who's pushing for this?
Yeah.
The payers.
Yeah.
Right? The insurance company and government is pushing for this and saying, hey, we can't let this happen. Like, you own the facility, it's part of your hospital, and you're just going to use that, like, NPI to sort of bill and get paid more.
Yeah.
Now, if you break that down, why it's happening as well, right? Look, Medicare, it's not a one-to-one match what they get. They get 82 cents per dollar.
Of course.
Right? So they're sitting there going, dude, you're not even giving me enough money to take care of Medicare patients. So I have to do these things.
Right.
So I think that's one thing. Now here, I'm going to throw the hospitals a bone. I'm not going to go after all of them at the same time. I got to throw them a bone.
Okay.
Because I think the rule itself, and look, again, it's made it through a lot of, passing, right? It's going to get passed most likely. It's in the Senate right now or something. Mm-hmm. But here's my one issue with this, okay? And I think somebody called this out as well. I think it's really unfair to rural hospitals. So I think there's got to be a discrepancy in this rule. Because look, in rural hospitals, dude, they are the one, right? So you're going to sit there and attack the rural hospital compared to the urban hospital. I think there's sort of got to be some sort of
carve out. And
then look, part of the carve out is, look, you're going to need to figure out what defines a rural hospital, mm-hmm. what's the zip code analysis, procedures, whatever it may be. Mm-hmm. So I think, and then you have to also police it. Mm-hmm. So that's my bone thrown out to them, saying, look, I get it. Like, rural hospitals, man, they don't want to end up with the short end of the stick.
No,
right?
No.
So
and already they're closing down and stuff like that, right?
And things like that. So I think that's a to me, that's a big issue that I hope that they consider in the rules somehow, some way. I don't know if there's an open comment period or whatever it is.
Yeah.
So I think there's, that's one piece. Now, this will create more competition, right? And so, which should impact price,
right?
But it should also improve the patient experience,
right? It should.
So I honestly think that if they flatten this and tell hospitals, look, you're going to get paid the same as the outpatient guy who's going to do the procedure or do the surgery or do the image or whatever.
Yeah.
You're going to naturally introduce competition,
right?
Which is great.
Yeah.
I think that's awesome. Mm-hmm. And I think the differentiator that we've seen in the consumer world becomes what? Experience.
Right.
And that's what we've been screaming about, right?
True.
We're in this whole consumer patient experience, revolution, if you want to call it, right? Which has different elements in it, like pricing and access and all that stuff. But if this creates that, that's wonderful. And then the other thing I'll say is, hospitals, you got to start focusing on stuff that you suck at, right? And you suck at a lot.
Okay.
Right? You suck at a lot. You have a cost issue. You've always had a cost issue. Mm-hmm. And, solving it by gaming the system is not the right thing to do.
Right.
If this happens in the public markets, we sue companies, right?
Yeah.
So hospitals, you've gotten away with it for a long time. Congratulations. Good job. You got your bonus. You got your lollipop. Put it down. It's time to actually focus on cost. So that takes me to, look, I have to say this. I have to say, what's the impact on tech? Mm-hmm. Right? So from a technology perspective, look, if these providers are going to start focusing even more on cost, they say they do, well then tech entrepreneurs and investors look at companies who are going to help you, right, control that cost. Because now that cash cow that you were getting because you were using your NPI on outpatient is going to go away.
Right.
To your point, that $1.4 billion reduction or whatever. You got to make up for it.
Yeah.
It's not coming from somewhere else.
No.
So you got to focus on cost. And then you know what else you're going to have to focus on? The patient experience.
Yeah.
You're going to have to focus on giving that amazing experience. And so I think there's that opportunity for technologists, for startups to sit there and say, hey, really look at what are they trying to sell to the provider and where's the focus?
Right. Right. I mean, not to beat a dead horse, Medicare and Congress are not the only folks looking at this. Yeah. There is this group called the National Alliance of Healthcare Purchaser Coalitions, representing employers, public, private, nonprofit, all of the above. And they issued a scathing report in September, and they actually coincidentally called, basically it's about, 10 myths about hospital pricing that they wanted to debunk.
Yeah.
And, it's quite striking. I mean, I remember myths going through the list. I looked at myth number 7 that really jumped out at me because that's something that I've heard too, that hospitals are providing a ton of uncompensated care and discounted care. And what this group, the coalition, cites is they go to a national, a nonpartisan state health policy group, and they use their hospital price tool calculator. And basically their analysis is that no, it's the opposite. They're not providing that much discounted care or uncompensated care. They're actually overcharging payers. So I think the heat is on hospitals. I still think that society at large, including myself, has a soft corner for providers because, especially during the pandemic, they were on the front lines, bearing the brunt of this disease, helping people, recover. So I think there is a well of sympathy for the hospital groups, but it's not going to last long if these practices don't change.
It's a thankless job.
It is.
Right?
It is.
And I love it because 7's my lucky number. So thanks for bringing up number 7.
But when you mention tech, I mean, I don't know, Samir. Because of my job, I get pitched, a zillion times a day on health tech. I mean, how do the hospitals even properly look at which tech they can use? Because all these are point solutions. Hospitals don't have the ability to do one point solution here, one point solution there. I mean, that's why I think, even though people will hate me for saying this, I'm actually happy that there is a shakeup happening in digital health. Maybe a lot of good solutions will end up with more platform type companies.
Well, and I think from an investor perspective and from an entrepreneur perspective, we do want to look at things that are more platform oriented, right? Especially if it's software, if it's health tech going into a provider area. It's different if you're talking about a med device, right? That's sort of solving for a solution or making, creating better quality for procedures.
Right.
But from a digital health perspective or from, from a software perspective, you do want to invest in a platform. But at the same time, look, I mean, I wouldn't, if somebody's building something very specific and unique, they also need to be aware that their exit could be a roll-up. Like, hey, listen, I am a point solution, and I'm okay with getting rolled up into a platform, right? So I think it's okay to do that.
Right.
I think providers are getting better at sort of looking at technology. I think there's an explosion of innovation and venture offices sort of, launching everywhere. And so I think it's going to get better. And I think, look, the big elephant in the room that's going to be there for a long time is AI, right? Data and AI. So I think that's going to definitely end up playing a role in sort of evaluating all these things, right? And so I think, look, the EMR sort of got it going, right? And, look at how that went, right? I mean, it's like you had lots of providers and now you've had a lot of consolidation happening in that industry. And so I think, from a what to look for and what solution to sort of roll out, one is I think they need to be a little bit more aggressive. They've been too conservative. And I think something like this site neutral payment thing is going to force them because you're not going to get any more money coming in.
Right.
You need to be more tighter. You need to be more efficient. And I mean, it doesn't take a genius to figure out that technology can make you more efficient if done properly.
True. Now, so Congress and these healthcare purchasing groups are not the only ones that are, laser focused on driving down healthcare costs. We're in March now. The state of California has instituted a law again. Listen to us, but talk to your lawyers. Come April 1st, there's something very interesting happening in California when it comes to large entities, either in-state buying another entity or out-of-state large entities buying healthcare entities in the state of California. So, Samir, you've studied a lot on this, so now you take over.
Well, so Office of Healthcare Affordability, right? So that's what they're sort of calling it. And there's really sort of the why behind it. Okay, so why was this office created, and why are you going to focus on it? Well, labor and employer perspective of affordability is sort of at the center of it, right? Cost growth, right? The healthcare cost cycle, right? We're paying more for healthcare. It's sort of going astronomical. Provider consolidation is causing this as well.
Absolutely.
Right? So people don't realize that when you see these mergers happening and acquisitions happening, I mean, you would think that, oh wow, this small little entity has now gone into a bigger entity. They're gone into a bigger entity, then I'm going to have better pricing because obviously they're getting more, economies of scale. No, it's gangster mentality again.
No competition, yeah.
Right?
Yeah.
Less competition, antitrust, I'm going to control it.
Right.
So California has sort of looked at that, and actually there's 13 states that have also done one part of that I'm going to talk about,
Yep.
and then 9 states that have done something called a cap growth, right? So cost cap growth.
Right.
So first,
Cost growth cap, I think.
a cost growth cap.
Yep.
Cap growth,
Yep.
whatever
Yep.
it is, right?
He's creating new terminology
I'm
here.
creating new terms, yeah. So, but let's talk about the first one, right? Let's talk about sort of the M&A one, and you nailed it. So, look, there are sort of federal thresholds that you have to meet when you are sort of doing a merger or an acquisition.
Sure.
So California is sort of introducing their level, and their level is basically like, dude, anything over 25 million, you got to come to us. So you literally have to apply.
Yeah.
You have to sit there and submit all your information 90 days prior.
Yep.
Right? And then this whole governing body reviews your application and has sort of an open period to go back and forth, and they kind of have to bless it.
Right.
So who does this impact, right? And so the next question becomes, well, oh my God, who's this going to impact? So obviously all hospitals, right? So hospitals and IDNs, right? Integrated delivery networks.
Right.
Physician practices, right? Oh, you're a physician practice and you're going to sell out. Great. Well, if you're over $25 million,
Yeah.
you're going to be on the hook to submit paperwork.
Right.
Right? And then, of course, payers. Right? So these are the 3 sort of organizations that we're going to focus on. Now, California, interestingly enough, is not the most expensive state for healthcare.
No, we're 32 in the nation, I found out. Yeah.
But our growth is one of the fastest.
Yes. Yes. Correct.
So
correct.
we're not bad, but we're not great at it, right?
Yes,
So I think that's
yes.
sort of the focus there, is that let's start looking at that. So, if you want to go buy a hospital, you got like a month or so to get it done. Right?
The clock is ticking.
Clock is ticking, get it
Yeah.
done. But if not, then you're going to have to sort of 90-day beforehand sort of do this. So I
Yeah.
think it's going to impact, a lot of these organizations.
Yeah.
And to your point, it doesn't matter if you're in California and you're buying something out, or if you're out of California and you're buying something from California. So I think it's going to go both ways.
Yeah.
And, a lot of them are sort of following what some of these other states have done, like Massachusetts and others that have done that. So,
Absolutely.
So,
yeah.
so that's one part of it. Now, the second part is this, what do they call it? Growth cap.
It's
cap
no.
growth.
It's cost growth cap. You are capping the cost growth.
Yeah, exactly. So what they're saying is, look, these costs, healthcare costs are, rising extremely.
Right. Right.
And they're rising more than income is rising. So they want to cap that at 3%. Right? They're saying, look, you know what? You can't have that more than 3%. Now, this rule has been introduced, and it's sort of in the inner circles, has been blessed,
Yeah.
but it still needs to go through a process.
Yes.
And so even if it comes to fruition, it's not going to be for another couple of years. Right? And so, again, who they're following, there's a couple of states that have done this. Massachusetts happens to be the one that has also done this and actually implemented it. One other common thing around this is that it's all blue states.
Yeah.
So 99%, like all the blue states are the ones who are sort of looking at this. Red states, I don't know what they're doing.
Well, my knowledge of this actually comes from a webinar that I viewed. So a shout out to Shepard Mullen. They did a great job,
Yeah.
on this, and they actually listed the states that are looking at it, and they listed the top 10 states that have the highest costs, and those are frankly all the red states. So I thought that was interesting because they are so much about government spending on a lot of their populations are on Medicare and Medicaid. So I found it interesting that they have not implemented any such rule. I think there was a question I thought that was really funny where someone said, oh, why can't we just move headquarters from California? Then we can do whatever we want, buy whatever organization we want, and we'd be outside this rule. No, I think it's really important to know that your where your headquarters is located has nothing to do with the law. If your assets or revenue derived from California is 25 million, you are subject to this. Now, before the comment period, MSOs or managed service organizations were part of this too.
Yeah.
Now they said no, they're not. But if a payer governs or owns MSOs, yes, very much. Then they are. So there's a lot of stuff to be worked on the cost growth cap side.
Cost growth cap.
Try saying that fast 3 times, right? And that's not expected until 2025 and enforcement not until 2026. But my question is, will it have a chilling effect? Is it intended to have a chilling effect on large transactions in healthcare?
I mean, I think it should, and I think it will.
Okay.
So I think, I think this is probably, like, if you take all these things that we just talked about, right? Site neutral, patient ag, pricing transparency, what's the common element here? It's pricing, cost, right? Like, so I think all those things coupled together should have a positive impact, right? And I think this, the 3% cap increase, the thing that's a little confusing right now to me is who's going to be under the gun for this? Is it just, again, providers, payers, and IDNs, or are you going to throw anybody in there? Because let's just be honest, like an employer has healthcare costs, right?
Right.
And so, what happens traditionally, right? So all this stuff that's sort of happened, right? Pricing and cost has gone up. When it comes down to the employer's ability to negotiate with the insurance company gets compromised, right? And let's just say they can't do what they can do. And then basically it comes to the employee, and then what's the employer going to do? They're going to pass the buck.
Right.
At the end of the day, who ends up paying for all this is us.
Right.
Right. So I think that this 3% rule, I'm really curious to see, like, who are you going to put into this? Like, are you going to put everybody into this?
Yeah.
Like, is Google going to be under the microscope for this? Is, like, Apple, like, are these companies going to be under the microscope? Or is this going to just be for, again, the healthcare entities, right, for controlling their costs? So I don't know what the right, we're going to find out.
Right,
we'll find out. Now, again, it comes back to, like, when I'm thinking about this as an investor and I'm thinking about this for my portfolio companies and entrepreneurs, wow, right? I sit there and go, okay, so, and a lot of times, some of these topics that we talk about, people are like, oh, it doesn't impact me, I'm a technologist. No, everything comes full circle.
Absolutely.
Right? So if you're a technology company, you're a startup, you're an investor, and your portfolio companies or your startup is selling into the provider space. How is that going to impact you?
Right.
So let's just be honest. Selling into a provider, it takes years, right, to get a contract. Small, big, large, doesn't matter.
Right.
Now, in the beginning days, when you were having, consolidation was sort of taking time, a smaller hospital is a lot easier to navigate and cut through the fat. Because you don't have these big departments, there's less bureaucracy. But now, if these things were getting acquired, like left and right, you'd have to go up to the big hospital. And you're sitting there going, oh, wow, great opportunity, I get to sell more.
Right.
Yeah. No, you're going to have to go through like 10 more departments now, more bureaucracy, more procurement to get approved. So I think this is a good thing in the long run, right? And this is sort of like the, most startups or investors want to hear, which provider or what client did you do a pilot with and stuff, and they want to hear these big names.
Yeah.
And I'm sitting there going, no, dude, I actually don't want to hear a big name. I want you to go to a smaller place because I think then you're going to get the revenue faster. The big people can come later.
Right.
So I think this is something that if it works, it'll actually help entrepreneurs.
Interesting.
So if they actually think and position their BD and their sales strategy appropriately. Right? And then again, of course, that whole process of like who are you going to sell to and how are they going to implement, those things are going to also change. They're also going to change and they're also going to, differ depending on where you go. So I think all these pieces, the site neutral stuff and all the 3%, cost growth.
No, you're still not getting it.
I did that on purpose. And then the threshold for M&A and stuff. I think all these things are sort of moving us in the right direction.
Yeah. So just quick clarification here. The 3% has not been decided.
No.
Okay. It's a number that was thrown out as something that will likely be that number in terms of the cost growth cap. I got it right. All right. But no, I know you're talking about these smaller tech companies, and this might be good for them because now they can work with smaller payers, whatever, and not have these issues. But I'm wondering if you're a larger tech startup, been around for a while, you were thinking of going public, and the market's not opened up. There's no guarantee that 2024 is going to be any good from an IPO front. That's not good for you. I mean, and please name names here.
No, and I think it depends, right? I mean,
What if I'm a Quantum Health? What if I'm an Omada? What if
I
I'm...
I get that. And I think, look, but here's the thing I'll say to you. Again, we don't know. This rule, again, applies to provider, payers, and IDNs. So what you're saying in that situation is, like an Omada is getting bought by a health system or a payer.
Exactly.
We haven't hit that point yet where
Yeah.
you're seeing massive, purchasing happening by them.
True.
Hospitals and IDNs, I still haven't seen them just acquire a company.
No, but what about retailers?
Yeah, I mean, but again, our retailers are not subject to this.
So CVS Health is not subject to this?
CVS is because they're CVS Aetna,
Right.
right? Walgreens is like, dude, I don't need to worry about this.
Oh, and you're sure about this?
Well, I mean, yeah, the rule is providers, payers, and IDNs. PBMs are not in this.
Oh, interesting.
MSOs are not in this. So
interesting.
So I think, does it maybe change the landscape of who you're going to exit to?
Yeah.
Yeah, because out of those three, who's been actually buying tech, if you think about it, is the payers.
Yeah.
Right? United has bought stuff, and
right.
CVS and all those guys.
Exactly.
So I think, maybe it starts limiting that, or you just know that, hey, you know what, my acquisition is going to get, under the microscope.
Yeah.
Like, of course, the federal microscope, but now I'm going to have to worry about it from a California perspective. So I think that is there. I don't, hospitals, dude, like if hospitals start buying like Omada tech companies, we got a big problem on that.
Yeah.
There's something really gangster happening behind the scenes that we don't know about.
But VC firms, again, can buy, and they're not going to be, will they be subject to the no, right? Like,
No.
let's say a wannabe General Catalyst wants to buy
like
something.
a PE can go buy it.
Okay,
Nobody
and they're
sat
not.
there and said PE can. Now, what's interesting, what you just mentioned is PE buying hospitals or practices. Aha, now that
is, yes.
Because it just has to be one part of the party. It doesn't have to be both parties.
Yeah.
It doesn't have to be a hospital buying a hospital.
Yeah.
It could be PE is buying like a list of cardiology practices.
Yes.
Or a list of like imaging centers.
Yeah.
Yeah, that is going to come under.
So we totally rocked a rule that's happening in a few weeks here in California. We nerded out on it for sure.
Yeah.
And I think that's it. Saying cost cap growth so many times
Cost cap growth.
has winded me out, so we're going to call it quits here. Again, please write to us at debunked@medcitynews.com. And again, I'm Arundhati Parmar signing off today. And
thank you, Samir Batra. Thanks again, guys. Take care.
Thanks.